Is that okay? Yeah. So today we can do 1 hour. From tomorrow maybe we can add up because tomorrow I will be free. So tomorrow we can add up. Today we'll do 1 hour. Is that okay? Yeah. Okay. So regarding the athlete's heart. So we have two types of athlete's heart. I don't think it's very high heel for step two, but we'll just quickly see a few points which might be questions. So there are two types of athletes heart. The one who do the strength training, the other people who do the endurance training. That these are the people who do the God, what's wrong? Okay, so these are the people who do the running, jogging, all those things. Strength training is the one, the weightlifting, all those things. So with the strength training, what happens is that the first point, it always with these kind of questions, I would recommend start having a starting point. From there, you can build. For example, for strength training, let's start from the increased haptic load because they are lifting a lot of weight, the muscles. So that's you know that hand grip also we use it for increasing the haptic load, right? So strength training also increases the afterload. Start from there. And if the afterload increases, can you tell me what are the causes of concentric ventricular hypertrophy? Yeah, very good. Hypertension. So whenever the afterload increases, hypertension is a condition where the afterload increases. That is the aortic blood pressure increases. So whenever the afterload increases, there will be concentric hypertrophy. Concentric hypertrophy is like the cup is getting being becoming smaller because the size of the wall is increasing. That is the concentric hypertrophy. So here the concentric hypertrophy happens, and as you know, afterload is for the aorta. So the right ventricle will be free of any changes in the strength training. Apart from that, but remember that here the concentric hypertrophy is a physiological adaptation, so it is not pathological. So the ejection fraction. Um, what is that? The ejection fraction, the cardiac output, the diastolic filling, all this should be normal. If these things changes, then it becomes pathological, which are the conditions like hypertension or aortic stenosis. These are the conditions where concentric hypertrophy pathologically happens. So that is the differentiating feature. Just the afterload increasing concentric hypertrophy, but the ejection fraction or the cardiac output or the diastolic filling, everything should be normal. Sometimes, ejection fraction and cardiac output could be high as well because, in the training, the demand is increasing, so the output should increase. So that is the basic need for this hypertrophy being happening. So you can have some questions might have cardiac output increasing, but basically, no pathological changes happens. That is the key. Okay. And for endurance training, I would suggest starting from the point where the heart rate is decreasing. So what happens is like people who are but remember the training that we are talking about here is like a long-term training, like people who are actually athletes, not the acute changes that happens to the exercises. That will be a different topic. Okay. So in endurance training, the heart rate will decrease. So when the heart rate decreases, the diastolic filling time increases. So basically, there is more blood. So this will be an example for the what is that? Eccentric hypertrophy of the left ventricles. So can you tell me the examples or the causes of the eccentric hypertrophy? Hello. Yeah, conditions for volume over. What are the conditions? All the regurgitant conditions and mainly the dilated cardiomyopathy, right? Dilated cardiomyopathy is an example for eccentric left ventricle, and diastolic heart failure is an example for concentric left ventricle hypertrophy, right? So here in eccentric left ventricular hypertrophy, but remember the same concept. This is physiological. Even though there is eccentric hypertrophy, this is physiological. So basically, the ejection fraction, cardiac output, all those things should be either normal or it should increase. That will be the key. So in this case, if you see in endurance training, the systolic volume increases. Why? Because there is increased there is hypertrophy of the cardiac myocytes. So that will contract with great strength, and that will increase the stroke volume. But what happens here is that even the end diastolic volume increases. That is the basic physiological change that is happening here because it is getting dilated, right? So the end diastolic volume is also increasing. So most patients will have normal ejection fraction. The reason is because of the stroke volume and the end diastolic volume kinds of cancers itself. And cardiac output, like I said, it should increase, but some cases they can be normal. But if you want to keep it straight in your mind, remember, start with increased afterload and concentric hypertrophy for strength training, and endurance training start with reduced heart rate and increased filling and eccentric left ventricular hypertrophy for endurance training. Remember, all the it is physiological, so no pathological changes should happen in the cardiac output or the ejection fraction or the stroke volume. Just keep that straight, okay? And the additional things, if you want to remember a little extra edge, there should be like reduced systemic vascular resistance in case of endurance training. The reason is simple, that you need more, the oxygen demand is increased in the muscle fibers and everywhere. So whenever there is hypoxia, they will release this vasodilatory substance that will reduce your systemic vascular resistance. And the blood, these people are having this hypoxic condition for quite a while. So they will have a tendency to develop increased blood volumes. The blood cells, plasma cells, everything increases, and that will cause increased blood volume. So that is an extra hedge, but I suggest you remember, keep these two things straight. Okay, clear? We'll move on to the next one. So this is what they have explained in the above paragraph, and the extra, yeah, remember, in the last class we talked something about the what is that, heart block. Can you tell me the causes of the first degree and Morbid's type 1 heart block? I told you the causes. Hello? No, 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 no. I am asking about first degree. This is the thing you will confuse, and this is a very high heel thing you should remember. So remember, first degree heart block and Morbid's type 1 is a one category, and Morbid's type 2 and complete heart block is a different category. This is like most non-symptomatic. This is like a passive one. This is like a milder one. So this is mostly non-symptomatic, and the causes will be either it's athletes or calcium channel blockers or beta blockers or digoxin. Anything that delays the AV nodal. So things that delay AV node or the calcium channel blockers, beta blockers, and the digoxin, right? And the athletes, they will have increased vagal tone, right? That is the cause of AV nodal delay. Just make sure that you understand the basics, be strong in the basics, because there's a high chance that the most of the questions that comes in the step 2 actual exams will be like very unheard of. But as long as you remember the basics well, you will be able to answer the questions. More than facts, give importance to the basics. So the cause for the first degree and MI is just the AV node is getting delayed a little bit. The reason for the delaying is either the calcium channel blockers or beta blockers or digoxin. These are the ducts which can cause the delay. It functions by causing the AV nodal delay. So that can happen. Or the athletes in whom the vagal tone is little higher than the normal people. So vagus is also it's a parasympathetic, right? That also causes AV nodal delay. So these are the causes for Morbid's type 1 and first degree heart block. Remember, these are non-symptomatic. It is like, it is okay. It's not going to cause a life-threatening conditions. But remember, Morbid's type 2 and complete heart block or life-threatening conditions, they are symptomatic, and these needs the treatment also, we need to place them on pacemakers. Okay, these two conditions we don't usually use pacemakers, but Morbid's type 1 CHP, we need pacemakers, and this is when the actual problem occurs. That is then fibers, the conduction fibers is getting affected. They itself is undergoing degeneration. Anytime we say degeneration, we remember aging, right? So aging is one of the cause of the degeneration. Or MI, if there is no blood supply, then then it can undergo degeneration, right? So MI or aging or causes of the Morbid's type 2 and complete heart block. Just don't confuse it. It is very important. Okay. So yeah, why did we come here? Yeah, so this patient is athlete, right? So for athletes, they obviously will have first degree heart block or Morbid's type 1. Just keep it straight in your head. Don't confuse the heart block, this heart block thing. And one more thing is, like I told, generally they have increased vagal tone. So if the vagal tone is increased, the heart rate should be lower. So they usually have a resting heart rate which is lower. Okay. And the next thing we'll move on to yeah, so maximum heart rate, yeah, normal people, if we exercise, our heart rate increases, right? But people like athletes who have been exercising for quite a while, this vagal tone would have increased, so their maximum heart rate would not be as high as the normal people. Okay, and there will be increased stroke volume, which we discussed earlier. So this is, yeah, one more thing I've told you here is the strength training. We saw that the afterload is increasing. That's the reason why the changes are only present in the ventricles, sorry, left ventricles. It's not present in the right ventricles. Okay. Whereas with the endurance training, the whole body is getting a I mean, if the heart rate is decreasing, the diastolic time and the end diastolic volume are increasing both in the right ventricle and the left ventricle. So the changes that we see in this patient, that is the eccentric hypertrophy, that is the enlargement of the ventricle size. All these things will happen both in the right ventricle and the left ventricle. Okay, that is something you should remember. So basically, they didn't cover anything except that here. And okay, so oh yeah, so what I told you, like this is like too much of an extra edge. Like I told you, like the blood volume increases a little bit, right, in endurance training and everything because of the constant hypoxia that that these people are subjected to. So whenever you have a high blood flow, you are subjected to pulmonic flow murmur, right? This is like a benign murmur. It has got nothing to do. Like this is because of the high stroke volume. Why is high stroke volume? Because of the high blood flow. Okay, because of the hypoxia and these things. And as we will discuss later on about what are the differential features between physiological murmur and pathological murmur. One of them is that murmur will disappear with supine positional changes and will, murmur will increase with supine position, and murmur will disappear with, when the venous fitness decrease. That is when the patient is made to stand and everything. All these things will happen with this pulmonic flow murmur as well because it is a physiological murmur. Okay. Um, am I going too fast? Is it okay for you? That's fine. Okay, fine. Next question. Next thing is like here. Yeah, this is a good question, but it is highly unlikely they will have such questions. So here we see a patient. He's a long distance runner, and he suddenly he had his team member suddenly died from some diseases, and they mentioned that the grandfather is having had an heart attack at the age of 40, and he underwent CABG, which we call it as cabbage, and he's having 49. So echocardiogram, just he's, remember, family history is significant, but this families, whenever they are saying like an athlete coming to you for cardiac evaluation, the thing they wanted to know is if he is having an HOCM or a condition which is similar to HOCM, other congenital cardiomyopathy. Okay, so your focus should be to know if the patient is having HOCM or not, and if the family history is having it, this condition. The family history that is suggestive of HOCM will be sudden cardiac death. Okay, not the MI and not the CABG. So just because they have a heart attack, if you are, for example, when you're quickly skimming the question, what happens? You will think, ah, there's a family history positive. No, this is not a positive family history for an athlete. Okay, so this is not a positive family history, and remember, this is like a team member, and he is also not a family. So the only thing that you have to concentrate is echo finding. So let's see echo finding. What happens here is left ventricle cavity size is increased. Okay, he is an endurance trainer, so cavity, that is normal. Okay, tick, and then left ventricle thickness is increased. Yeah. So what happens is, like I told you here, that the strength training, there is a concentric hypertrophy, thickness increasing, and endurance training, there is like eccentric hypertrophy. But remember, even in endurance training, there is a very little bit of hypertrophy. Basically, both are hypertrophy, right? So there will be increasing in the myocytes. That is constant in both. So wall thickness will be present to a minimum degree in the endurance training as well. This is this is like an extra edge, but they will not ask you questions with that, but they will confuse that point in some question. They will use that point as a confusion point in some questions. For example, this question, you might think that it is supposed to be like mass should be normal. No, mass will increase in both in eccentric and concentric hypertrophy. That you should remember. One more thing is yeah, and there is a wall thickness. Wall thickness will increase, but the increase will be uniform. If it was a HOCM question, the increase will be in the irregular. For example, the increase will predominantly in the septum, and even in the septum, the infundibular part is where the thickness is predominantly in. Always remember, the infundibulum is like this weak point for the septums. Either it is like tetralogy of Fallot, or it is like HOCM. The thickening is predominantly present in the infundibular portion. That gives an irregular thickening, and that irregular thickening will favor the outlet obstruction, both in the tetralogy of Fallot and this HOCM, because both are conditions which involves the interventricular septum, right? So there it is like this portion like on the right side, here it is on the left side, okay? And this gives the sigmoid shape of the heart. So if they mention something like the septum is sigmoid shape, the septum is irregularly thickened, or the left ventricle wall is irregularly thickened, that are the points that is differentiating HOCM. But here uniform thickening, uniformly increased left ventricular mass size, these are all normal findings, do not confuse, okay? And one more thing, and the ejection fraction. I told you ejection physiological condition, ejection fraction, stroke volume, and output should be normal or increased. That I already told you. So this also ticks the box. So only confusing point here was the wall thickness or the mass. You have to remember that these things will happen in any type of eccentric or concentric hypertrophy. That is not a differentiating factor. The differentiating factor is the output, ejection fraction, and one more thing is the irregular thickening should be there. Okay, and usually there will be like some questions will mention like left atrium is increased, some questions will mention normal. I would suggest in case of athletes, the thing you are usually differentiating is the HOCM or the normal finding. Don't go for left atrial finding. Like just ignore it. It is like very confusing. Okay, so yeah, so for this patient, everything seems normal to him, and there is no family history as well. Okay, and remember they have also given extra clue, which is the right ventricle cavity is also increased, which you will see in the endurance training, right? So this is a normal cardiac adaptation. Okay, so that is done. Like I told you, always an athlete, they are telling if the question is about an athlete, the thing they will ask you is differentiate between HOCM or the normal adaptation. Okay, so look for a irregular thickening of the left ventricle or irregular thickening of the septum, and also look for the dysfunction, that is ejection fraction, stroke volume, and cardiac output will become what in HOCM? Hello. Yeah, cavity size, even cavity size. Remember, these four factors will decrease in HOCM, which should be normal or increased in adaptation. Okay, are we clear? Till here? Yeah. So just a quick brush up of everything that we said so far. Like here, it's the same. Remember, ECG findings don't concentrate on two things that I will never encourage concentrating on is the ECG findings and the left atrial size in case of differentiating between athlete's heart and hypertrophic cardiomyopathy, because they are confusing and both are like both have T wave inversion, because if anytime you have a left ventricle hypertrophy, it is kind causing little bit of ischemia, and that will cause T wave inversion, and it is very non-specific. Okay, so the T wave inversion will be there. So don't use that or the left atrial size to differentiate. Differentiate using the what are the outputs that I told you here, or using the wall thickness. Okay, and one more thing is like I told you, it's focal segmental hypertrophy seen with HOCM and diastolic dysfunction. Dysfunction is not a physiological thing, so you will not see it in athlete's heart. You will see it in the HOCM. Okay, got it. Like I told you, do not use left atrial enlargement as a differentiating factor or the T wave inversions, which will be like very non-specific. Okay, so here we have a 17-year-old boy. He came in with yes, yeah. This is also a very interesting question. 17-year-old boy. He came in with left-sided chest pain or chest discomfort. Remember, he's saying that chest discomfort is exaggerated by left arm movements and deep inspiration. Can you tell me the DDs for chest pain that is increasing with deep inspiration or inspiration? What? Any? Yeah, pleuritic cause, either pleural effusions or pleuritis, these things will increase, or even pulmonary edema, all those conditions also sometimes they might mention, because even that there is a little bit of pleural irritation there. One more thing is the costochondritis or any musculoskeletal causes, they will also have pain on the deep inspiration, or any even the flyal chest, all those conditions. The reason is the breathing, right? So there is when the breathing, when you breathe, the chest expands and the muscles and bone is also involved in that. So that will cause what do you call it? Yeah, that will also cause little pain, right, when the patient breathes. So deep inspiration pain, you just don't limit yourself to pleural causes. Also have that in mind, this could also be a musculoskeletal cause. Okay, have that in back of your mind. So this patient, we are having deep inspiration pain, but they haven't mentioned anything related to the pulmonary cause here. But he's just a 17-year-old who usually plays soccer. Okay, and as you can see, they have mentioned T wave inversion, which we will not use, but echocardiogram finding, which is important here, says that slightly enlarged left ventricle cavity size and mild left ventricle wall thickening. We know both of this is normal in case of a endurance training. So that this patient is most likely having an athlete's heart. It's not so this question, it's not even about it's not even about differentiating between HOCM or anything. He's having chest pain. So chest pain, it's mostly this chest pain is definitely not a MI pain that we know it. Deep inspiration, it could be pleural cause, but you remember what, there is nothing that is mentioning there is discomfort in breathing or dyspnea or anything. So it's a straightforward question which says athlete's heart. Here, one more thing I wanted to mention is the cardiac amyloidosis. Can you tell me what is the type of heart failure that you will see in cardiac amyloidosis? Hello? Yeah, both. Just tell me everything. Yeah, you'll have restrictive cardiomyopathy. Restrictive cardiomyopathy will cause what type of heart failure? Diastolic heart failure, right? What sided heart failure? Quick, quick. So restrictive cardiomyopathy will cause right-sided heart failure. Restrictive cardiomyopathy, constrictive pericarditis, all these conditions causes right-sided heart failure. So what are the symptoms of right-sided heart? This is a highly high yield. That's why I'm mentioning, because um, none other options are important, but this is high yield. There are a lot of questions. Restrictive, constrictive, all causes right-sided heart failure. What is the presenting features for right-sided heart failure? There will be elevated JVP, there will be there could be ascites, there will be edema in the limbs. But what is the thing that differentiates right heart failure from the left heart failure that we discussed in the last class? It is that the patient will not be having crips. The patients will have dyspnea because the right ventricular output is decreased. That can cause dyspnea, but still the patients will not have crips, or the patients will not have pulmonary edema. So these two are differentiating features between the right heart failure and left heart failure. And this anything that is causing deposition like amyloidosis or hemochromatosis, all of these things will cause restrictive cardiomyopathy, which is nothing but a right heart failure, which will present with these symptoms. Remember, hemochromatosis, amyloidosis, all of this can also cause dilated cardiomyopathy. So it's not that it's only going to be restrictive cardio. Initially, when the substance deposits, it's going to be restrictive cardiomyopathy. But as days pass on, this heart failure will go progress to dilated cardiomyopathy, which will present as a left heart failure as well. That you have to keep in mind. Fabry's disease and all is not needed, and there is something called masked hypertension. What they're saying is like if the patient is having hypertension, but whenever you measure, sometimes it is normal and sometimes it is abnormal. The blood pressure keeps fluctuating between the in a single day, then that is what they're called as they call it as masked hypertension. I don't know it results in the hypertrophy. It's just like other hypertension, it's just as difficult to find it. It will result in concentric hypertrophy. That's what they're saying. This it's not highly significant. These are the things that we already discussed. Okay, so there's nothing new in here. Yeah. One more thing is steroids and OCPs, all these things. They will ask questions from any direction. They will ask in the uh, gynecology part, or they will ask in the cardiology medicine part. So it is whenever you see the steroids thing, you have to remember that point is very important. So what happens when the patients who takes with this steroid, anabolic steroids, is that they will have pathological concentric left ventricular hypertrophy. Steroid users are also mostly athletes, right? But if they are, so this is not physiological. So these people will have concentric left ventricular hypertrophy, but they will have reduced diastolic function. That is a thing. If a patient say, if they say like this is like a athlete who came in with difficulty in, having exercise intolerance and all those things, and you went on to do the echo, you find concentric left ventricular hypertrophy, which is normal, but the patient had reduced diastolic function. Think about anabolic steroids as well. Okay. And next thing is acute exercise changes. It is very low yield, so I will quickly say just few points. Okay, whenever you do exercises, your muscles oxygen demand increases, and that will cause vasodilated release of substances like what you want. You want to skip it? Okay, let's just skip it. Yeah, we can skip it. Next thing is like arterial. Yeah, next thing is in exercise they're asking what is the ventilatory changes. Yeah, this is important. There is something called venous blood and arterial blood. it is true that exercise causes an hypoxia. So that will because the muscles are taking a lot of oxygen than they are supposed to. That increases the O2. Sorry, that increases the carbon dioxide and decreases the O2 in the venous blood. But what happens is because of the changes that is happening in the lung, that is hyperventilation, minute ventilation, all these things increases. What happens that leads to, you know, the arterial blood, the oxygen and CO2 gets corrected. So basically, only the changes you will see is only in the venous blood, arterial blood, O2, PO2, I mean O2 and CO2, everything is going to be normal. Just the venous blood will have reduced O2 and increased CO2. Just remember venous blood. Exercise, normal athletes, venous blood will have increased, but arterial blood is going to be normal. The reason is hyperventilation and increased minute ventilation. What is the formula for minute ventilation? It's tidal volume into heart ventilation rate, right? Respiratory rate. So these people will have increased respiratory rate, so they will have increased minute ventilation. Because I'm saying this because many questions will mention about minute ventilation. They will not mention about hyperventilation or respiratory rate. They will say minute ventilation. The reason is increased minute ventilation. That is what is causing the normal blood levels of O2 and CO2 in the arterial blood. Okay. Next we will go to the eye altitude. So in here they have mentioned multiple things. So I wanted to keep things straight. First, the patient is remember. I assume a patient is going to the high altitude. The PaO2, that is atmospheric O2, is low. That will cause hypoxia. That is PaO2 is, in the arterial O2 is reduced. And what happens is when the hypoxia, the reflex will be to increase the respiratory rate, right? So respiratory rate increases and that will wash out all the carbon dioxide. When the respiratory rate increases, carbon dioxide is washed out, right? So that will cause reduced PaO2. If you remember it, you will this one line you will be able to answer most of the questions. Atmospheric O2 is low, arterial O2 is going to be low, respiratory rate increases, and PaO2 will decrease because of the increased respiratory rate. Okay, and this is like physiological changes that is happening. So remember, in all parts of the body, the concept that you should remember is all parts of the body, whenever there is hypoxia, that causes vasodilatation, right? Substances like substance P and a lot of other what is that, nitric oxide, all those things released in the blood when there is an hypoxia. But only one exception is that, which is the, tell me one area where hypoxia causes vasoconstriction. Hello. Yeah, it's in the lung. It's a pulmonary. In the pulmonary, that the reason for that is that it is trying to conserve, direct the blood to the more ventilated area compared to the unventilated area. That is why in the lungs alone, whenever there is a hypoxia, those region there will be vasoconstriction, right? That vasoconstriction is the reason for all the problems that this patient in the high altitude is facing. So, what are the problems? I just copy pasted it from somewhere because it is super high healed. So what happens when the patient is going to a high heat? Sorry, when the patient is having this pulmonary vasoconstriction. First problem is acute mountain sickness. That is like you and me, everybody can have this problem when they go to the mountains. That is headache and nausea, which will be mild and it is manageable. It's nothing going to be called. It will get better in a few days, 1 or 2 days. So headache and fatigue is headache and nausea is okay. But what happens after that? These two problems are life-threatening: cerebral edema as well as the pulmonary edema. The reason for pulmonary edema is that this vasoconstriction is not going to be happening in a similar way. If it happens in a similar way, it will be causing pulmonary hypertension, but that is not the case. That can happen in patients who are having chronic hypoxia, like because of what? They are living in the high mountain. These patients can have pulmonary hypertension because of the chronic pulmonary vasoconstriction. But when a patient is acutely, like recently they've traveled and reached the mount altitude, what happens here is this constriction happens irregularly. For example, in this blood vessel, this region is constricted, this region is normal, and again this region is constricted. So what happens? Hydrostatic pressure in this region is increasing. Okay, because of the increased blood, so that will cause the fluid to go out, and that will cause pulmonary edema. Okay, that is the cause of pulmonary edema. Cerebral edema reason is, I mean, brain is like other region, will cause vasodilatation for hypoxia. So hypoxia is happening, so it will dilate the blood vessels, increases the cerebral blood flow. When there is increased blood flow, also it causes increased hydrostatic pressure, right? That will also cause cerebral edema. So these are the three changes that will happen if they say. So if they say a patient is coming to the came to the altitude, the patient is feeling mild headache and nausea, then it is acute mountain sickness, which they will not ask most of the times. But they will ask if they mention something about the patient came to the altitude and he is having respiratory distress, dyspnea, and even sometimes cough and hemoptysis. Then they are mentioning pulmonary edema. If they mention something about gait disturbances and confusions and disorientation, then that is cerebral edema. Just make sure you are able to differentiate between these three conditions. Okay. Mm. These are like the physiological changes which they don't ask anymore in the step two. The only thing they ask here is there is increased PaO. I mean, hyperventilation is will help with the increasing the PaO2. At the same time, it will decrease the PaCO2. So if the PaCO2 is caused, it will cause a kind of respiratory alkalosis. So that you can remember. Kidney, it will produce increased erythropoietin that will as a compensatory in a tube. It will not happen immediately. It will take at least 3 days or even weeks for this compensatory changes in the kidney to happen, which will be increased HCO3 and everything, and increased 2,3 BPG. It is very first step one content. Okay. So here, are they mentioning something important? Yeah. So that's what I said. Idiopathic pulmonary hypertension can happen for patients who are present in the altitude for a very long time. I think these are all like mean arterial pressure, diastolic pressure, systolic pressures are considerably different. Okay, so there's nothing important apart from that. Okay, next is the panic attack. Okay, so here panic attack, the problem itself, here we saw the problem is the PaO2 is getting, that is atmospheric O2 is getting reduced. That is the problem in the high altitude. But the problem with the panic attack, the PaO2 is normal, but there is hyperventilation is the problem. The patient is having a pathological response causing the hyperventilation. So this hyperventilation will also drive out carbon dioxide, and this so PaCO2 will decrease, and that will cause respiratory alkalosis. So the problem is because of hyperventilation. The PaO2 will be normal in this patient. So that is what we have to remember. That is how you differentiate panic attack from these conditions. So here it might be seeming easy for you because we started knowing that it is a panic attack and high altitude. But when you see a question, it might be difficult to differentiate. Remember, PaO2 should be important. And the common thing will be PaCO2, but remember PaO2 is important as well. Okay. We'll move on to the next one. Next is exercise in children's. I think it's not that important, but remember we have a like this what do you call it? A bad idea that children should not do weight training and everything. So this question is to say that that is a wrong fact. Children's usually when it comes to endurance training, children can work out up to I mean more than an hour of even vigorous exercise, no problem at all. Hiking, running, jumping, they can do anything. They can do even vigorous exercises. They can do more than 1 hour. That is no problem at all. Okay. And when it comes to strength training, the problem is not them doing the strength training. The problem is them getting hurt because they are very hyper energetic and everything. They might have injuries, either ligament injuries, or they might drop some weights on them. They can cause fracture and everything. So that is the problem, not the fact that they are. I mean, they are doing the strength training, because strength training itself does not cause any effect, any bad ill effects in the children's. So anybody more than remember, just check few have these few checkpoints. If they are okay, just that is okay to have the allow the child to undergo weight training. One is age should be more than 8 years. There should be minimum requirement, and they should be cognitively mature. It should not be like Down syndrome, intellectual impairment. Those things should not be there. And then it should be under the supervision of the qualified person, because to avoid all this complication. That's it. If these three things are okay, then go ahead, allow the child to undergo weight training. It's not a problem. It's not like they are going to have stunted growth or anything. That are all just myth. Okay. Okay. The other complications would contraindication would be HOCM or any other heart conditions. If they are asking you to screen the child, if a similar question comes and they ask you to screen the child, the screening is going to be for HOCM. Either it is for screening for endurance training or strength training, doesn't matter. If they're asking a young athlete or a young child who's coming to you for screening, they're asking you to check. Mostly, you have to go for echo and look if the patient is having echocardiogram. Look for the changes like I told you, like stroke volume, ejection fracture, thickening of the ventricles, all those things you have to check and see if the patient is having HOCM. If he doesn't, then we can allow them to undergo training. So mostly the questions will be athlete came to you saying that he's going to undergo training, and what will you do to test? The testing will be echocardiogram, and what will you check for in this patient? The check you have to check for wall thickness and all those things. And some questions they will give the wall thickness and stroke volume and ejection fraction. They will ask you what condition is the can you allow this patient to undergo? Yeah, you can allow the patient if the what is the things in the echo findings are normal, the one we discussed in the between the difference between the athletes and the HOCM. Okay. Okay, next one is yeah, here this question. So this is the same question. A 9-year-old boy, he came, his father is a trainer, so he's a 9-year-old and he wants to begin a strength training. He's interested in everything. Would you recommend it? Of course, you should recommend it. And next is the S3 and S4, which is a very, very important concept, which is very high yield. Okay. So S3, the concept for S3 is that S3 is like an overfilled tub. You're trying to fill it again. That is the concept of S3. So whenever there is a dilatation cardiomyopathy or there is some kind of regurgitation, either in the mitral valve or in the aortic wall, some kind of regurgitation condition, this causes overflow, right? So there will be at that in those cases when the HM is pouring blood into an already overfilled ventricle, then that will cause that sound of that blood pouring into this heavily filled ventricle is going to cause S3. Okay, that is the physiology for S3. Okay, so and then remember the physiology for S4. S4 is that you are trying. Remember, you are pouring a blood or you are pouring a liquid into something like a cardboard. Okay, so if you are if the blood is getting striked by very thickened or very stiff ventricles, that is going to cause S4. Okay, and example for that. Okay, let's just see the examples later. So S4 is that S4 will be that. So we'll see the examples of S3 first. This normal condition, just don't remember it. Just remember the abnormal. They don't ask any normal things anymore. So S4, the abnormal thing is like I already told you, there should be regurgitated conditions, either aortic regurgitation or mitral regurgitations. And one more thing is dilatation, that is dilated cardiomyopathy. And this heart disease, I will tell you later. And one more thing is high output heart failure, like high all I had output heart failure conditions will have an increased preload, right? High output heart failures will have what do you call it, increased heart rate, and that will cause increased venous return and everything. So they will basically have increased blood volume. And high output heart failure, you don't have to confuse like high output heart failure from normal heart failure. Both are dilated cardiomyopathy only diastolic heart failure is going to be concentric hypertrophy. Okay, high output or dilated cardiomyopathy, both are same, just the causes are different, and few factors like systemic vascular resistance, all those systemic vascular resistance and preload, those things will be different, but both are dilated cardiomyopathy. Diastolic heart failure is what is the concentric hypertrophy will be there. Okay, so don't confuse that. So there is no difference between dilated cardiomyopathy and high output heart failure. Both are basically same, just the concept is a little different, but both are dilated only. The ventricles is going to be like eccentric hypertrophy only. Okay, did you get it? Yeah, so both are going to be dilated cardiomyopathy. So just remember dilated cardiomyopathy and regurgitant conditions. And here, when we come to S4, here it is the diastolic heart failure, right? Because here in diastolic heart failure, it is concentric hypertrophy, which means the wall is very thickened. That is which is like a cardboard. So when the blood strikes on it, it will cause S4 sound.
Oh, sorry. Just 1 second. Can you hear me now?
Yeah. So yeah, so this is like a diastolic heart failure. And when it comes to MI, S3 and S4, this is where you have to be careful. And acute MI, a ischemic heart will act like a thickened heart, stiff heart. That is what will cause S4. Okay. MI, acute MI will cause F4. But remember, some patients with MI will go on to develop heart failure, left heart failure, right? Those patients will have S3 because S3 is a feature of heart failure. That is either ischemic heart failure. Ischemic heart failure will go on to cause dilated cardiomyopathy, right? So that dilated cardiomyopathy is going to cause S3. So this will be confusing in some questions. So make sure you remember that acute MI, the MI wall itself will cause S4. Whereas the MI, if it goes on to develop heart failure, that dilated cardiomyopathy is going to cause S3. Okay, just keep this straight. Okay. All volume overload is S3, and if there is a thickening of the wall, then it is going to be S4. And remember, S4 is just before S1, and S3 is just after S2. Okay, that is, I think it's basic. Um, so we'll move on to the next one. Yeah, so can you tell me now, right? Because we have discussed, can you tell me heart failure causes which, S3 or S4? I mean, hypertensive heart disease causes which, S3 or S4? Yeah, S4, because it is like diastolic heart failure. All the causes of diastolic heart failure will come under S4 only. So that example is hypertension, and then aortic stenosis and hypertrophic because these are all outflow obstruction. Any obstruction will increase the pressure first, okay? Then only volume increases. So all the outflow obstructions will cause diastolic heart failure, which is concentric hypertrophy, which is S4. At the same time, all the condition which causes dilatation, like regurgitant conditions, not the stenotic conditions, regurgitant conditions. Okay, all the regurgitant conditions will increase the volume first, not the pressure. These conditions will cause S3. Okay, and these conditions will cause eccentric hypertrophy and dilated cardiomyopathy, and this will cause S3. Just keep these facts straight. Okay, diastolic heart failure, concentric hypertrophy, S4, stenotic heart disease, or hypertension. Whereas dilated cardiomyopathy, S3, will eccentric hypertrophy will be regurgitant heart diseases or dilated cardiomyopathy. Clear? Is it too fast? Okay, fine. Next one will be, okay, yeah, well, let's see what they're saying in this question. This is the same, chronic hypertension will cause S4. There's nothing difference. So in this question, what they're saying is like a patient, a 54-year-old man, he came in with chest pain since yesterday night. Okay, so for one night, he's having chest pain, which is causing sweating and shortness of breath and radiating. So all these are features of MI. Okay, so they're asking what physical finding you will see. Obviously, it is S4. Okay, not S3, because if it is an S3, then you might get confused. So it is S4. Okay, and yeah, we'll move on to the next one. So okay, like they will ask you where you will find this S3 and S4 better. Everything in cardiac apex, and it will, sometimes it is best here with the left lateral decubitus position if you wanna have an extra edge. Okay, next is a JVP. So when it comes to JVP, always it gets confusing when it comes to what is A and when it comes to what is C and everything. How I keep it straight in my mind is like you have. Remember this wave pattern. The highest point is the increased pressure, and the lowest point is the lowest pressure. Okay, so if at which point is the atrium having highest pressure? When it is contracting. So A is for atrial contraction. Okay, and then remember C is for tricuspid, because this is like a small bulge. What will cause a little change in pressure? That is when the tricuspid valve closure. It is also simultaneously when the right ventricle is contracting. When the right ventricle is contracting, this tricuspid valve will bulge a little bit, and that will cause this C wave in the JVP. Okay, and then what causes a pressure to fall down? What causes the pressure? This X wave is because of the right atrium relaxing. Okay, relaxation will cause the pressure to fall down. Okay, and then it is also the and then what causes the pressure to rise and reach a peak? That is it's, we saw the highest point is the contraction. Then the next highest point should be when the blood is getting filled, right? So V is for filling of the blood. The right ventricle is getting, the right atrium is getting filled. That is for V. Okay, and then Y is for emptying. That is, after filling, it should be emptying, right? So it should be white. One more thing I forgot to say here is, can you tell me a condition where both S3 and S4 will never be seen, even if there is even if there is regurgitation or stenosis, you will not see S3 and S4 when? Hello. Yeah, so that is during atrial fibrillation. So remember, in a question, they might ask you this as a separate question. So when there's an atrial fibrillation, one of the things that you will never see is S3 and S4. The reason is for both S3 and S4, the blood has to come to the ventricle. Either it is striking and thickened wall, or it is striking and overfilled. It doesn't matter. It has to come and strike, right? For that striking thing, you need is atrial contraction. That is called atrial kick. So that atrial contraction should be there for S3 and S4 to happen. That is like a prerequisite. Okay, in atrial fibrillation, there is no atrial contraction at all. The reason I'm saying that is when the blood leaves the atrium and enters the ventricle, there's two phases. Either when the valve opens, just due to gravity, blood will enter. That is not the phase when the S3 or S4 happens. Okay, but when the atrium contracts, the blood will come with a force and then hit the ventricles. That is when the S3 and S4 happens. This atrial contraction or atrial kick will not happen in atrial fibrillation. Okay, so atrial fibrillation is a condition where you will not see S3 or S4 even if you have that associated valvular diseases. Like mostly atrial fibrillation, one of the important causes valvular diseases, right? It is an important yeah, so it is that's why we differentiate the management into valvular diseases, non-valvular diseases, and even in atrial fibrillation, whenever there is a valvular cause, then it is very difficult to treat, okay, because it is resistant to most of the treatment. So when they mention a valvular disease, still they mention atrial fibrillation, you should not see S3 and S4. That is a important fact that you should remember. um, Here we saw normal JVP. Okay, we'll move on to the next one. Do you have any doubts in the normal JVP? I think it's very step one content. Next is this one. Yeah, this is very important fact. I mean, yeah. So here it is benign and pathological murmur we are trying to differentiate. There will be a lot of points here. I will try to tell you what are the things that will actually help. Okay, always look at the murmur. Okay, forget about the rest of the history and all. First, look at the murmur. History and everything is just an additional factor. They will try to confuse you. Just look at the murmur. The murmur, look at the grade. The grade more than or 3 is the pathological murmur. Okay, and also remember, murmur which is holosystolic or diastolic is definitely pathological. It is not. You will remember diastolic that we have seen many times. Remember, holosystolic is also pathological only. Okay, but yearly or mid systolic can be benign murmurs. Okay, remember holosystolic and diastolic, and remember grade 3. This one sometimes they might mention a not harsh murmur, and here it is like benign murmurs will be musical or vibratory and everything. And one more thing it is important to remember is like with the maneuvers, usually physiological murmurs will decrease with the standing and decreases or disappears with standing and valsalva. If the intensity is still persistent, it is still a very strong murmur. Like for example, this feature will be present in both the murmurs, like the decreasing and the decreasing in the intensity will be present in both the murmurs. But the thing is the intensity still intense enough to call it as a pathological murmur? The intensity will still be 3 or something. Even if it decreases from a little bit, it will still be a highly intense murmur in case of pathological murmur. That you have to remember. Okay, so it might be confusing. This point where the maneuvers reducing the intensity of the murmur can be confusing. It should disappear or should be very low in grade to call it as pathological, but it should be decreasing but still a higher intensity to call it a pathological murmur. Okay, so these are the definitive points. Okay, what happens is like some question they might mention, usually you should not have a family history for benign murmurs, but some questions might mention it to confuse you, mostly in the usual questions. So don't keep it as a main thing. One more thing is poor weight gain. If it is a pediatric patients, they will mention about the poor weight gain and everything. That is important. It could be an important clue in case of pediatric patients, and it could be symptomatic as well, but these are like not the important points. And one more thing is the S2 S3, mainly the S1 and S2 mainly the S2. They will mention this S2 thing in a lot of questions. Like they in a physiological thing they will still mention an S2, but they will say a physiological S2. The thing is they will say that there is two component S2 split. Normally S2 is split only, so it is normal only. S2 is split, and they will also mention something like it increases with inspiration. That is also normal only. So they will mention all these features. Just because they're giving an explanation for S2 doesn't mean it's pathological. Remember, splitting of S2 is normal, and the splitting is prominent during inspiration. That is also normal. Pathological will be wide fixed S2, or a paradoxical S2, or uh, persistent splitting of S2. Can you tell me the examples of persistent splitting of S2? What? Yeah, right bundle branch block or right-sided heart pathologies will be persistent. And paradoxical is like all left-sided heart pathology is paradoxical. Wide fixed will be always what? Yeah, AST. So that you have to remember. So just because they will just because they are mentioning about S2, they're saying the splitting and all, it doesn't mean it's pathological. Look carefully if they are mentioning a physiological change. Okay. So these are all confusing. And then the cyanosis, they might mention cyanosis, but not all cyanosis are pathological. Physiological cyanosis like peripheral cyanosis, the cyanosis limited only to the digits or to the outside of the lips. It is physiological. Pathological cyanosis is when the cyanosis should be present all over the body, or it is present in the mucosal membrane inside of the lips. That is pathological. Okay, just because they mention cyanosis, it doesn't mean it is what is that some kind of pathology. Okay, and then in this kind of murmurs, you should check ECG and echo, mainly echo, which we will this point I will address later on. Okay, so things that I want you to keep it straight is that pathological murmurs should not be a systolic murmur. I mean, will mostly be holosystolic or diastolic murmurs, and it should be intensity 3 or more. And the valves, you should be careful when it comes to differentiating using the manuals. Okay, and also be careful when they are mentioning S2 or when they are mentioning cyanosis. Okay, use the murmur as a differentiating point, not as this family history and the other points. Okay. Mm. And just because we are here, we can see about this physiological murmur. Still's murmur is it's all these three murmurs, still murmurs, pulmonic murmurs, and venous hum, all are physiological murmurs. So they will have the features of this physiological murmur. Okay. Only differentiating feature is where it is happening, which region it is happening. For Still's murmur, it is left lower sternal border, which is nothing but near the tricuspid area. Okay. And then with pulmonic murmur, it is in the pulmonary area, that is left upper sternal border. With venous hump, it is going to be infra or supraclavicular region. The rest of the thing, it is same. The rest of the thing, it will be the same, the physiological characteristic features. So the physiological characteristic features in the area, in the different regions, will be these what is that, innocent murmurs. Okay, and one more thing I wanted to specify here is this radiating. Okay, some physiological murmurs will radiate. Radiation doesn't mean it's a pathological. Radiation is not a feature of pathological murmur. Okay, that you have to remember. Hope we are clear. We'll move on to the next one. I'm just rushing. Okay, so I'm not sure if you understood everything. Just tell me if you didn't. Okay, so yeah. So in this question, the baby is a 5-year-old boy. He came in for annual examination. Remember here also they're trying to confuse you with maternal uncle have MI. Maternal uncle having MI in a young patient has no significance. Okay. Um, and then here it is a S. So let's see one by grade of murmur. So nothing matters. Family channel you should not consider. Okay, because when it comes to murmur. So grade 2 murmur, which can be physiological. Vibrative can also be physiological. Mid systolic can be physiological. Best here and the child is lying down and decreases in intensity with standing. Yeah, this is also a characteristic of physiological. S2 is split. This is where it's confusing. S2 is split and it varies with inspiration. It is a physiological. Normal people, you and I will have S2 split, which will vary with inspiration. So that is normal. So don't get confused. Okay. And then femoral, rest of the thing is normal. What is the best next step? It is a physiological murmur. Just reassure the patient. Okay. Always look the murmur when it comes to you want to find if the murmur is a physiological or pathological. Look at the characteristic of the murmur. That is very important. And one more thing is you can look at the area to find which type of murmur it is. Okay. Don't look at family history will be confusing. Don't look at it, and don't get confused with the S2 splitting thing that they will say, and also don't get confused with the radiating. These things will be present in both, so don't use that as differentiating point. Okay. Next is Valsalva. So this is they will not ask Valsalva in step 1 or step 2 anywhere. Just remember in Valsalva, the straining phase, Valsalva is nothing but you're just blowing a balloon and preventing the, venous return. Okay. That is what. So venous return should decrease in Valsalva. So that is the concept. Okay. And what they will not ask which phase this changes happens, definitely no. But you just remember, maybe in straining phase is the phase where you are blowing, where this pressure in the intrathoracic, I mean intrathoracic pressure increases. Okay, so that is where all these changes that I told you, that direction in the venous return and increase in the heart rate, all those things happens. And one more thing you can remember is in Valsalva, most of the changes is blood pressure primary change. The heart rate changes is secondary to the blood pressure changes. Okay, that you can remember. So these are all not needed. Okay. And this is very high yield, which is very high yield. This variation is very, very high yield because they will ask questions from all directions when this comes to this table. Okay. We'll go one by one. So most of the murmurs, whenever there is an obstruction murmur or stenosis murmur or regurgitant murmurs, murmurs should increase when the uh, blood through that valve is increasing. For example, this is the pathological valve. So if any maneuver that increases the blood flow through this valve, it could be any direction. So that will increase the murmur. Okay. Only exception will be HOCM and MVP, because in HOCM what happens is that when the blood volume increases, the cavity size increases. When the cavity size increases, the valve obstruction decreases. So when the obstruction decreases, the murmur will decrease. So except HOC, the same concept will go for the MVP as well. Okay. So only in HOCM and MVP, the murmur will decrease with increase in the blood volume. Okay, that is the first concept that you should remember, no matter what. All the other places, whenever the blood volume increases, the murmur will increase. That is the first point that you will remember. So with this you can answer most of the things. Okay, let's go for this three things, because these are the very important, and this is just an opposite of these three. Leg raising is an opposite for these three things. So with Valsalva maneuver, abrupt standing, squatting, all of, sorry, not squatting, so sorry, these three are same. Valsalva maneuver, abrupt standing, and passive leg raise. All these three things will decrease the blood volume, right? They are decreasing the blood volume, like it reduces the, um, yeah. So they reduces the right ventricle and left ventricular preload. I think I confused you. One second. So Valsalva maneuver, abrupt standing, both of these things will reduce the right ventricle, left ventricle preload, and that will increase the decrease the murmurs of MVP and HOCM and increase the other murmurs, all the other murmurs. This is the same as the concept that we discussed. And squatting, it will increase the blood volumes, that will increase the murmurs of other things, whereas it will decrease the MVP and HOCM murmur. That also same as the concept that we discussed. Passive leg raising will increase this blood volume, that will increase the other murmurs, will decrease the MVP and HOCM. So everything is based on this one concept only. Okay. And the hand grip, which is increase in afterload. All these three things are preload, increase or decrease in the preload. Okay. Whereas this hand grip is the increase in the afterload. They won't ask it mostly. Okay. They mostly don't ask it to differentiate, but maybe you can remember, like if the afterload is increasing, all that the blood flow still it's the same. The blood flow through the AR, MR, and VST, AR, MR, and VST increases in these conditions. So the murmurs will in these conditions will decrease. Remember, HOCM, MVP, and even aortic stenosis, the afterload increases, the blood flow will decrease, right? So that will cause decrease in the murmur. So whatever may be the question, just remember this concept. When the blood flow through a affected valve is increasing, the murmur will increase in all conditions except HOCM and mitral valve prolapse. That's it. Okay, so in aortic stenosis, what happens is that when the afterload is increasing, there is more obstruction, right? Already there is an increased pressure that is stopping the blood from going, and there is also afterload which is increased, so that will also stop the blood. So there is less blood flowing. It actually a very severe condition, but still the murmur is decreasing. The reason is the blood flow through the valve is decreasing. Okay, you got it? Clear? Yeah. So with inspiration, it's like the same thing. The right ventricle preload is increasing, and whereas the left ventricle with inspiration, yeah. So the intrathoracic pressure increases, so that will cause more blood to come to the right ventricle. Whereas the left ventricle, it still will be low because the venous return to the left ventricle is decreasing, right? So that will cause more right-sided murmurs will increase and left-sided murmurs. This is like a totally different concept. They don't ask this, and they don't ask this. This is like very, very important. Okay. These two things are very, very important. Just keep this one concept straight. Just blood flow through the valve is increasing or decreasing. Is it HOCM or MVP? That's it. Okay. And then next is the aortic stenosis. Okay, when it comes to aortic stenosis, the thing you have to remember is like most important cause is the calcific aortic stenosis, which happens in elderly patients. When I say elderly patient, it's 70 years or old. In 70 years or old patients, it's like they become too old, and their valves are getting so tired. Calcification occurs in this aortic valve, and that will lead to what? Aortic stenosis, right? So that is the most common cause. But one more tricky thing in this thing is like in most U world questions I've seen, like they always mention 70 years or older than 70 years when it comes to aortic stenosis. But in NBME questions, they go even down to 60 years. So 60 years or more, you can keep 60 years or more. You can suspect aortic stenosis in a symptomatic patients in 60 years or older. You just don't have to stick to the 70-year concept, because I've seen NBME asking that for 60 years as well. Okay. And what are the other causes of aortic stenosis? Apart from the aortic calcification, which is 90% of time, it's going to be aging. Other things could be bicuspid valve or rheumatic heart disease. These two things you can remember. If it's happening in a younger patient, it could be bicuspid valve. Or if it's like if the patient is happening, it's just if they it's all in the history. Like if they say mention a younger patient, or if they mention somebody who came from the developed country recently immigrated or anything, it's going to be rheumatic heart disease. Okay, but mostly it will be calcific disease. But they no longer ask us to diagnose the condition. Like elderly patient, they are having any murmur, similar systolic murmur similar to the aortic stenosis, is going to be these conditions. Yes, so they no longer ask us to diagnose the AS anymore, but it is going to, the questions is going to be regarding the treatment or the what is the investigation of choice, or any some other tricky things that they mentioned here. So we'll see what are this. What are the severe? So what the things in AS that needs treatment is the severe AS. Okay, severe AS needs treatment. Asymptomatic, sorry, if it is not severe, you don't have to treat the patient. That is clear, okay? Because if you go on to treat all aging patients with the AS, you literally need treatment for everybody more than 70 years. So that is not possible. So only if it is severe, you are going to need treatment in case of aortic stenosis. So what are the conditions? What are the things that will show that the patient is having severe? Anybody who is symptomatic is severe only. So I always remember, like in case of AS, severe is equal to symptomatic. So whoever is symptomatic is they are having severe. So all people who come to you with symptoms are severe, and you have to treat them either with what is the treatment, I'll tell you in the later. So first thing is symptomatic, and then the second thing is the echo findings. What I mentioned. Okay, so echo findings, I will tell you what are the echo findings. There are three classic echo findings that will tell that the patient is having severe symptoms. So one thing that is important is like the peak. So what is the murmur that you will see in AS? Yeah, so what's systolic murmur? It is crescendo decrescendo systolic murmur, right? In the aortic region, which is like right sternal border, right upper sternal border. So yeah, so the thing is the peak, the time taken for the peak to happen. In case of severe, if the peak is happening late, then it is a very severe disease. Okay, let's say if the peak is like this, then it is less severe. If the peak is happening late, then it is a severe disease. One point. Second point is S2. Usually you should see a splitting in the S2, right? Yeah, which is aortic component and pulmonary component. It is more prominent during inspiration. This is physiological. But what happens in here is that aorta takes too much time because the pressure difference is too much. The ventricle has to increase the pressure up to the aortic pressure for the aorta to open, right? So it takes little time. So what happens in these patients, like the S2 becomes delayed. The aortic component of the S2 becomes delayed, that it fuses with the P2. So you will not see a splitting at all. So no splitting or a soft S2 is the feature for severe disease. So it is little contrast. You might think that a loud S2 is like a symptomatic for aortic stenosis. No, a soft S2 or a S2 which is not split, that is the feature of severe aortic stenosis. Okay, what is the third point? Third point is pulse. by measuring the pulse. Pulse is parvus et tordus. What is parvus et tordus? The patient should have a weak pulse. Basically, the cardiac output, the patient is having very severe obstruction. There is no cardiac output at all in this patient. So that is causing a very weak pulse, and the pulse is also very delayed. Like it should happen. There's a time, right, for between S1 and S2. So it is very delayed and it is also very weak. That is a feature of severe disease. And one more thing is the valve circumference. If the valve circumference is less than 1 centimeter, that is also a feature of um, severe disease. These are these are the echo findings. Okay. Yeah. So what will be the investigation of choice when you suspect a patient with aortic stenosis or any valvular disease in that case? Yeah, echo is the investigation of choice. Aortic regurgitation or aortic stenosis, mitral regurgitation, mitral stenosis, whenever you suspect these conditions, the investigation of choice is like echocardiogram. The reason I'm saying this is now it will seem easy, but when they mention you will have an aortic stenosis patient coming to you with symptoms of chest pain. They will say chest pain, they will say dyspnea, exercise intolerance, all those things. They predominantly say chest pain. Remember, aortic stenosis patients can also have angina. Angina is not a feature for MI alone, okay? But and then they will give the options about exercise intolerance or biomarkers and everything. Don't get confused. If it is aortic stenosis related angina, you are having symptoms related to aortic stenosis, go for echocardiogram. Okay, same goes for other valvular disease as well. Can you tell me the investigation of choice for pericarditis? Hello, hello, hello. Yeah, what happened? I can hear you now. Yeah, so what is the investigation of choice for pericarditis? Yeah, it's echo. It should be clear. You should not think for these questions. Pericarditis, tamponade, any valvular disease or valvular disease treated and going in for complication, all these are echo only. Now it will seem easy, but when they give lot of history, it will get confusing. Just remember the facts straight. Pericarditis, tamponade, valvular disease, or complications after treatment of the valvular disease, everything you have to check echo. Okay. um where are we? Yeah. So what is the treatment? Now we finished the diagnosis, we finished the investigation, then we'll go for the treatment. What is the treatment for AS? Treatment is all valvular disease surgical treatment only. And what is the surgical? We are there are two surgical. Either you can go trans valvular aortic repair, or you can go for open heart. We are not in old age, so we are nowadays doing transvalvular only. No one does um, open heart and all. And one more thing I wanted to remember is this symptoms. Like a lot of conditions have similar symptoms, so it gets little confusing. Remember, this patients will have predominant aortic stenosis. Cardiac output is decreased. That is the cause of all the symptoms. One is they will have exercise intolerance. Okay. Second thing is they will have dyspnea with exercise and or activity, any activity. Okay. And then all these things will be progressive because the obstruction is progressively increasing, right? Progressive. Okay. Sometimes they will have syncope or pre-syncope with activities as well. So either it's dyspnea or syncope or pre-syncope or with exercises or exertional dyspnea, exercise intolerance itself, everything progressively increasing. These are all features of the aortic stenosis. Keep the symptoms little clear as well. Like it will be confusing, but see the history, like if it's a old man more than 60 years, in those cases you can go for aortic stenosis. And murmur is the most important clue as well. It should be a systolic, like I said, crescendo decrescendo murmur. And remember the area and murmur will never lie. Always I get confused with the questions, but when you go back to the murmur and the area, it becomes clear. Okay, so the area for the aortic stenosis will be the right upper sternal border. Remember, sometimes they will mention the left sternal border as well, but here the left upper sternal border is for the pulmonary area, but one area below the left upper sternal border is also again aortic area only, but that area is mostly for the aortic regurgitant murmur, especially the HOCM or valvular murmur. But sometimes they might mention the aortic murmurs there as well. You should be able to a little bit correlate. If the symptoms are very much towards the aortic stenosis, remember these two areas can be okay. Like, are you clear? Should I go to murmur? Should you be going to the murmur again? Yeah, like just give me 1 second. Yeah. Yeah, so this is like an aortic area. Okay, okay. This is like pulmonary area. Okay, and this is tricuspid area. This is mitral area. These things and all will be clear. Okay, but tricuspid area, there will be additional murmur. VST murmur can also be heard in tricuspid area. Remember, pulmonary area, the additional murmur is PDA can be heard in pulmonary area. But when it comes to aortic and pulmonary, stenotic murmurs will be heard here only. Stenotic murmurs will be heard in aortic stenosis will be heard in aortic area. Pulmonary stenosis will be heard in pulmonary area. But when it comes to regurgitant murmur, aortic regurgitant murmur, supravalvular aortic regurgitation will be heard in aortic area. Valvular or HOCM murmur will be heard in one area below the pulmonary area. Okay, pulmonary regurgitant murmur sometimes will be heard in pulmonary area or one area below the pulmonary area. Okay, you got it clear now? Yeah. So the regurgitant murmurs, when it comes to aortic and pulmonary, will be little confusing. It can be heard in aortic area or one area below the pulmonary area. Pulmonary regurgitation also, you will hear it either in pulmonary area or one area below the pulmonary area. So just keep this areas alone clear, and then the murmur type. These two things will help you differentiate between how much ever question might be confusing. Come back to the murmur and the area. That will mostly help you to differentiate. Okay. Um, Next thing, yeah, one more thing I told you, like it's um, aortic stenosis will cause concentric hypertrophy. Concentric hypertrophy can cause S4. You see S3 and S4, go back to the causes. If it is causing, then it's fine. And then sometimes they're saying severe AS can cause sudden cardiac death. That is too much. Yeah. So in this question, they are mentioning a 48-year-old. 48-year-old, it's the same aortic stenosis, harsh murmur, and all the region and everything is same. 48-year-old, if it is a murmur, there's only two causes. Either it is bicuspid heart disease or rheumatic heart disease. There is no mention of the immigration here. So it is going to be bicuspid heart disease. That's it. Straightforward. Like I said, they will mention mostly less than 70 years, but when it comes to NBME, remember even up to 40, sorry, even 60 years is okay. So 60 or more itself is like okay for aortic stenosis, to diagnose aortic stenosis. And this is one more question where they mentioned the same thing, like mm, what did they say? Yeah, this is like one more thing, the soft and single S2 during inspiration. So S2 should be split during inspiration, right? If it is soft or if it is single, then it is feature of ES. Okay. And yearly peak systolic murmur. This is the thing you should remember. Like yearly peak is not a feature of severe disease. Late peak is the feature of severe disease. This is how they confuse it. Okay. That is more time is taking to for the blood to be pushed out. That is the late peak. That is the concept behind late peak. Okay. Next thing is here. Yeah, again, here it is a 73-year-old man. They mention about the lightheadedness, and they also mention about like jogging and everything. He becomes lightheadedness. He undergoes fainting, and he's also having dyspnea, and he's also having chest discomfort. So this chest discomfort part is what is causing. We think that it is this patient is having angina, that is stable angina. What happens in stable angina? Stable angina patients will have chest pain, but their cardiac output is not compromised, so they will not have. Lightheadedness and all. They will have chest pain during activity. That's it. But here, the patient's predominant symptom is exercise intolerance. With activity, he's having lightheadedness, syncope, and pre-syncope. And remember, angina can be present in the ES as well. Remember, that's why this is causing chest discomfort. Okay, and that is what is So this is basically what patient. This patient is having AS, okay, and he is also 73-year-old. So the symptoms are sometimes they don't mention murmur, but this is mostly in the case of UWorld. I don't think they will say have such a question in NBME or actual exam. So AS can have angina as well. That is the key here. But predominant symptoms will be exercise intolerance or syncope or pre-syncope with activity. So investigation of choice is echocardiogram. That's what they will try to confuse with you with the symptoms, but if you are able to rule out it as AS, then it is going to be echocardiogram. Okay. And then, yeah, here it is like a 70-year-old patient. And again, they mentioned the same thing, ejection site type of murmur, left ventricle. Remember, again, ECG finding is not um, it is very non-specific when it comes to valvular disease as well. They will have ST segment elevation, they will have TV invasion. All these are because of the ventricular hypertrophy, not related to the ischemic changes. So don't use ECG to differentiate a valvular disease. This patient is having the age-related what is this aortic stenosis as well because of the senile calcification. Here, this is like a too much of a question. The patient comes to you like comes with a chest discomfort for the past 6 months. He's having pressure like sensation and all those things. He's having hypertension, hyperlipidemia, everything, and he's also having AS. That also they mentioned. The aortic valve is restricted. So they're asking you to differentiate if this angina is because of AS or if it is because of what is that MI. So here it looks like this patient is having MI. This AS is like a incidental finding, but they will not ask any such confusing questions. I remember you stick to the facts. Okay, like I said, murmur, area, AS, or the severity symptoms like echo findings and symptomatic, then it is AS. If it's chest pain and if the patient is having hypertension, hyperlipidemia, or smoking, all these things, it will be like MI. They will not use such confusing questions in actual exam or NBME. These confusing questions happen in UWorld only. You will start to think like complicated way because of this UWorld questions and end up answering simple questions wrongly. So just stick to the facts. These questions they will not ask in actual exam. So when you see advanced stage hypertension, hyperlipidemia, smoking with classic MI findings, then it and chest pain, then it is going to be MI. Okay, don't get confused with AS and all. Okay, they will not give AS features and all in those questions. Again, this question is also almost the same. It's like yes, weak and slow rising. This is pulses parvus et tardis. Okay, that is what is weak and slow rising pulse. So they are asking what if the patient, this patient is a symptomatic AS patient. I told you all symptomatic patients are severe. Symptomatic is equal to severe. So if it is severe, which of this following features should be there? It should be like weak and slow pulse, that is pulses parvus et tardus. Other features will be S2, which will be soft and single, and you could have a late peak, or if it will be less than 1 centimeter diameter. These things can be there. Okay, this is the same symptoms that they mentioned. And also remember hypertrophy. Yeah, they will have concentric hypertrophy. Yeah. Yeah, so yeah, tell me. Last question, this question. How to arrive at this diagnosis? Yes, look, if this patient they have mentioned already, the patient is losing consciousness with, remember it is a old age patient, and he is having an exertional syncope, right? Old age patient with exertional syncope. Okay, this is itself is a clue. Next question is like the next point is like he had similar, so it is progressive, similar episode a month back, and physical activity over the year due to the process. Yeah, progressive exertional dyspnea and fatigue, that also they mentioned. There is no chest. The only thing that will cause progressive exercise intolerance, if they're saying progressive exercise intolerance and syncope, pre-syncope, cardiac output is decreasing, right? But this for cardiac output to decrease, this patient is not having MI. So the only thing differential that is left behind is the ES, right? An elderly patient, also for MI, you should have chest pain, and that is also not present in this patient. Okay. The other reason in an elderly patient for reduced cardiac output is what? AS only, right? And also, even if you don't find AS, look at these options. Blood pressure differential between upper and lower extremity is seen where? Coarctation of aorta, right? Coarctation of aorta, if either it should be congenital or it should be disease like, what is that, Takayasu arthritis, those things. Both are not going to present in a 67-year-old, so that is gone. Late diastolic murmur at cardiac apex. Late diastolic murmur at cardiac apex is what? Mitral stenosis, right? Mitral stenosis, what are the causes of mitral stenosis? Rheumatic heart disease, or it should be like endocarditis. So this patient definitely not endocarditis, no fever, no features of and it is not rheumatic heart disease. He did not have any childhood illness. He did not have any. He did not migrate from any place. So this is also gone. And then next is the prominent capillary pulse on the fingertip. Prominent capillary pulse. Remember, prominent capillary pulse or hammer pulse or the head bogging. All of this is happening because of increased pulse pressure. What is pulse pressure? The difference between the systolic and diastolic blood pressure is the pulse pressure, right? So when the systolic blood pressure increases very high and the diastolic blood pressure decreases very low, that is when the pulse pressure decreases. Whenever the pulse pressure increases, there will be this head bogging and the hammer pulse. The concept is that your systole is going so high, but the diastole is suddenly dropping. That causes this vibration inside your body. The vibration, you are able to feel it in the peripheral pulses, in the head, or in the capillary pulses. This is and what is the differential for increased pulse pressure? This is very important concept. What is the differential for increased pulse pressure, or the water hammer pulse, or head bogging and increased capillary pulse? What? Yeah, yeah. Okay. Yeah, high output out. Okay, that's fine. So this is aortic regurgitation, mitral regurgitation, those things, or high output heart failure, like you said, and also PDA. Remember, PDA also, it's the same concept. This the heart, so like I told you, systolic blood pressure depends on the cardiac output, right? And diastolic blood pressure depends on the systemic vascular resistance. So cardiac output is so high, all of these conditions, regurgitant movements, cardiac output is so high, but all the output is coming back immediately, so that is causing low diastolic blood pressure. That is the reason. And PDA is also the same concept. All the blood is the left ventricle venous return is very high because all the blood, a lot of blood is coming from the pulmonary vessels, and that is causing increased systolic blood pressure. Whereas systolic blood pressure is immediately dropping during the diastole. The reason is because all the blood that came to the aorta is going through the PDA to the pulmonary vasculature. That is also the same concept. Then high output heart failure is heart failure is also the similar pathology. Here, instead of the PDA, there is systemic vascular resistance. The cardiac output is increased because of the increased venous return, but immediately the systemic vascular resistance is also low. That is causing the decreased diastolic blood pressure. Okay, all of this are same concept. If the underlying concept, if you're able to understand, you can tell this causes PDA or all regurgitant conditions, high output heart failure, or any places where the venous return increases at the same time systemic vascular resistance decreases. All those things. Even the one more thing is that septic shock. I've seen a lot of septic shock questions, so make sure you remember it. Septic shock, which is also same concept, and also that what is that? A fistula, or yeah, a malformation, aortic Oh God, vascular malformation, right? There is connection. Sorry, AV fistula. Sorry, I suddenly couldn't remember. Yeah, heavy fistula, septic shock. All this also causes for the what is that? Increased pulse pressure and the boggy head and all those conditions. Not just the regurgitation and the high output heart failure. Just make sure you remember it. So this patient is obviously not having any of these symptoms. So it is also not, out of systolic blood pressure more than 10 mmHg with inspiration. Systolic blood pressure more than 20 mm. So this is what is this? A sign called when systolic blood pressure drops more than 10 mm, it is pulsus paradoxicus, right? What is the differential diagnosis for pulsus paradoxus? Tamponade, constrictive pericarditis. These two are the differentials, and also COPD and asthma. This is like a very important point. You must remember it. When it is a pulmonary cause, pulsus paradoxus because of COPD, asthma, and if it is a non-pulmonary cardiac cause, it's going to be tamponade or constrictive pericarditis. This patient has none of the symptoms of tamponade. Tamponade will have muffled heart sounds, hypotension, and JVP elevation. This patient doesn't have that. Constrictive heart failure, constrictive pericarditis also have similar right heart failure symptoms, right? We saw that restrictive cardiomyopathy and constrictive pericarditis will have right heart failure symptoms, will be elevated JVP, ascites, edema, and everything. This patient have none of those symptoms. So this is not a pulmonary pulsus paradoxus either. Next is this is like systolic blood pressure drop more than 20 mmHg is the what is that? Um, hypotension, right? Orthostatic hypotension. Okay, so in that case, the patient should have giddiness and everything, but that will be when the patient is trying to get up from the chair or is trying to get up from the bed yearly after sleep. That is also not there. So none of these are there. This is straightforward exercise intolerance and exercise activity induced syncope, pre-syncope in an elderly patient. It is aortic stenosis. Straight away, if it is symptomatic aortic stenosis, severe aortic stenosis, so it is going to be weak and slow rising pulse. Got it? Yeah. So remember pulsus paradoxicus and all is very, very important. Also make sure you remember whenever pulsus paradoxus is mentioned, don't just go for the tamponade or constrictive pericarditis. Also have COPD asthma on the side of your brain. Okay. One more thing is that what is that I mentioned? Yeah, that's it. So next thing is what are the things that needs treatment? Like I already mentioned it, any severe aortic stenosis needs treatment. What are the conditions? Severe stenosis, symptomatic or valve size or echo findings. This aortic jet velocity, mean transversal waist, don't remember it. They will not ask any questions. Just remember the severe symptomatic and echo findings. That is enough. Like I mentioned, late peaking and pulsus paribus et tordis also I mentioned already. And what are the conditions that needs valvular replacement? Like I said, all the severe conditions will need valvular replacement. That is one. And sometimes they will mention ejection fraction as less than 50% as severe. Actually, you don't have to remember it as a separate point. Like I told you, like aortic stenosis itself means reduced cardiac output. If it goes, I told you, all symptomatic people are severe patients. So when the ejection fraction becomes less than 50 only, they will become symptomatic. So that also that is an indirect way of saying that it is symptomatic. One more thing is if the patient is undergoing some other cardiac manipulation, for example, he got MI and you're going to do him as CABG, you can do the AS along with that as well. It's just you concomitantly you can repair it. That's what it is. And also at this point, I also mentioned there is a flow chart for valvular replacement in the U world. It is a very important flow chart. Just make sure you go and see it once. I mean, I could see it and insert it, but I didn't have time. But if you want, I will send it after this class. There's a flowchart for aortic. If a patient is undergoing surgery, then if they are found to have valvular disease, do you operate the patient or not? For this, there is a flowchart. Just make sure you have a look at that flowchart as well. I think you probably would have included it. I am not sure. Next question. Next question is like. Yeah, this is all here. If they will mention some point regarding the severe disease here, they mention he is already symptomatic. Oh no, he is asymptomatic. He's not symptomatic, but the valve size is 0.9 centimeters. So less than 1 centimeter is severe disease. Severe disease needs treatment. So this patient recommend valve replacement. Okay. Okay. Next is the what are the complications of the yeah. So what are the complications of the aortic valve replacement? So you have done valve replacement for this patient. So what are the complications that might arise in this patient? So first complication will be like, let's see, this is the valve, and you have placed the replacement. Okay. One thing is if it is a mechanical valve that you have placed, this mechanical valve will not correctly bind with this our actual valve wall, annulus. So that will cause a leak. This is paravalvular leak. So that is more common with a mechanical valve. One more thing you have to remember is like if you placed a bovine valve, what will cause this valve will fix perfectly, but the thing is it will easily degenerate. The valve itself will degenerate. That will cause transvalvular leak. So these leaks, transvalvular and paravalvular leaks are common. One more thing is this again this is a new valve, right? Our body will produce sorry immune cells and everything. So that will cause thrombus or some kind of emboli formation, then can cause stenosis and obstruction. So these three are common things. But what specifically I wanted you to remember is this MAHA, that is microangiopathic hemolytic anemia, which is very common. You know that all patients with what we have studied in step 1 is that all patients with mechanical valve can have this schistocytes and everything because of the the damage that it undergoes while crossing that mechanical valve. But if they mention that the patient has undergone mechanical valve replacement, and they are and he is now having schistocytes or microangiopathic hemolytic anemia. The most important cause is this complication. This complication is what will drive these changes, will damage this what is this RBCs. So when they mention a patient who underwent a mechanical valve replacement, now he is having a histiocytes, or he is having anemia, or he is having a microangiopathic hemolytic anemia, what is the investigation of choice? Can you tell me what is the investigation of choice, or what is the differential? Investigation of choice is echo, because you have to do echo and see if there is this changes, this complication that has arisen in that valve that you've replaced. Differential is the either this paravalvular or transvalvular leak or some kind of obstruction. Okay, so don't just think there is a normal finding. What do you want me to go and investigate? No, if these findings are seen, then the patient is this valve is undergoing some kind of abnormality. The valve that you've replaced is undergoing some kind of abnormality. That is the most common reason why this patient is having this MAHA and schistocytes. Go on to do an echo. Echo is not, it's for all valvular disease. Either the patient has valvular disease, you go for echo. If the patient had valve replacement, now he's going for complication, again the investigation of choice is echo. Remember that. Okay. Okay, you also make sure to remember what are the changes of that you will see in MAHA. That is like LDH will be increased, and hepcidin will decrease, and there is bilirubin. What is that? Indirect bilirubin will increase. All those things also you should remember, because that's how the question will be. They connect all the system. They don't go just for the CVS system, right? So they will mention that the patient who recently underwent, or a few years back underwent mechanical valve replacement, now he's having elevated LDH, hepatocytes, and bilirubin rise. Sometimes they might mention cystocytes, and they will mention anemia and things. So what is the investigation of choice? Echo is the investigation of choice. What is the diagnosis? This valvular abnormalities is the diagnosis. Okay. Diagnosis is echocardiogram that we discussed. Let's go for the question. Yeah, this is the same question. So this patient underwent mechanical valve replacement, and he's on warfarin and everything. Now he is having murmur in the same area where you replace the valve. And so what is the best next step? Just do the echocardiogram to see if there is any complications for this arise from the valve. This is also a similar question. There's not much changes. This is also a dysfunction of prosthetic valve. And one more complication, this is like a secondary complication that might arise following this valve. This valve, any foreign body will cause emboli, right? This emboli can dislodge, and that can cause stroke. That is one complication. MI is that sometimes this valve, aortic valve, is very close to the, just in the, where is the coronary blood vessel arises from? It arises from the root of the aorta, right? Especially in the right coronary vessel that arises from the root of the aorta. So when you place the valve, you might damage this coronary ostia, and that can cause MI. So it can cause MI and stroke. This is like a secondary complication. It might seem in this course in these conditions. And let's see what this question is. It's like a 62-year-old woman. She has systolic ejection murmur, best ear at the second right intercostal space. ECG and echo, everything seems normal except the left ventricular hypertrophy. It's a straightforward question. What are the following manifestation would indicate the need for the aortic valve replacement? Like I told you, it's an straightforward. Look at the murmur. When it's confusing, go for the murmur. Systolic ejection murmur, area is also okay, and there is little hypertrophy as well. They already told you that what is the need for the aortic valve replacement? Like I told you, severe condition. Severe is equal to symptomatic. Symptomatic is angina and syncope. Done. I don't know why suddenly innocent murmur is being mentioned here. Primarily pulmonary. So yeah, so what they're saying is like if you have sometimes, you know what is pulmonary hypertension, but if they're saying like a pulmonary stenosis, if you have pulmonary stenosis instead of in the pulmonary artery, you have it very distally in the smaller pulmonary vessels or in the branches or anything. In those cases, you can hear a pulmonary flow murmur, it seems, one of the innocent murmur. But that is, I don't think they will ask any questions regarding that. Okay, can we stop here? It's been 1.5 hours, I guess. Hello. Can I what? Oh, this one. Pulmonary edema and ascites. Why are we seeing pulmonary edema and ascites in aortic stenosis? The patient is not having heart failure. The patient is having aortic stenosis. It's true that aortic stenosis can cause diastolic heart failure. It can cause these symptoms. I mean, the ones you said, but is that is like too much of you know complications? Okay, first we consider they didn't mention anything about that diastolic heart failure. If the patient has diastolic heart failure, the patient might have even more severe symptoms, right? But it is like a straightforward iotostenosis condition. She came for a routine health maintenance examination. She's not even recognizing her own symptoms because all the severe symptoms I mentioned, right? That will be seen in patients who walk. Most symptoms happens when the patient does some activity, right? Only on activity the patient, when the patient walks and everything, they will have pre-syncope or syncope or dyspnea. All the symptoms are with activities. For people who don't do any activity, just keep sitting, they will not have any symptoms at all, and they will find it even if it's a severe disease, they will be asymptomatic. Only when they come to you, you will find that it is symptomatic. So that's why this patient is probably not having mentioning symptoms, because she does very less activity. And then when you throb into it, you will find the patient will have angina and syncope. You got what I'm saying? So always, like all heart conditions will lead to heart failure, but we cannot give any question, any diagnosis. They will ask what is the symptoms that you're expecting to see in these patients. This symptoms and many other disease, this disease and many other disease will lead to heart failure. Don't mention the heart failure, the symptoms here. Mention this direct symptom of this condition. Okay, this pattern you will observe in many places. Don't mention the complication symptoms of the complication. Go for the direct, straightforward symptom of that disease. Okay, got it? Yeah, yeah. Uh, let's stop it here. Let's continue from tomorrow. I think this pulmonary stenosis and aortic regurgitation alone is like a very simple thing. I can finish it like quickly. Tomorrow's class, I think yeah. So tomorrow I will try to come here earlier, most probably. Okay. Yeah. Okay. See you tomorrow.